We described the PK/PD and toxicodynamic properties of antifungal agents and explained the pathophysiology and clinical presentation of candidiasis and aspergillosis. We also looked at guideline recommendations for invasive candidiasis. Now, given a patient with invasive pulmonary aspergillosis, let's recommend guideline-concordant treatment. So here are the 2016 IDSA guidelines for the diagnosis and management of aspergillosis. So the first line therapy that's recommended for pulmonary aspergillosis for initial, and initial means that, we're not talking about salvage therapy, meaning somebody has already failed a treatment. So what should we do? So initial therapy is, literally they just had pulmonary aspergillosis. So we're just starting treatment for the first time. So the primary recommendation is voriconazole is the drug of choice. So the standard of care for pulmonary aspergillosis is voriconazole. So not any azole, voriconazole. And combination antifungal therapy, so voriconazole plus one of the echinocandins may be considered in select patients with documented invasive pulmonary aspergillosis. Now, primary therapy with echinocandin monotherapy is not recommended. So as I had mentioned previously, azoles perform better against aspergillus compared to echinocandin. So echinocandin monotherapy is not recommended, only as a combination. Now, alternative therapies include either liposomal amphotericin B or some of the newer azoles. So isavuconazole would be an alternative, and that's essentially because that's a newer agent, more expensive, and less data at the time that the guideline came out. Nowadays we have more experience with isavuconazole, so it's a pretty effective drug for pulmonary aspergillosis. And then echinocandins can be used in the setting in which azole and polyenes, so amphotericin B, are contraindicated. So that's when we would do echinocandin monotherapy, when we have no other options available. Now, early initiation of antifungal therapy is strongly, when invasive pulmonary aspergillosis is strongly suspected, is warranted. Now, duration of therapy is recommended to be a minimum of 6 to 12 weeks. And it largely depends on the degree and duration of immunosuppression, site of disease, and evidence of disease improvement. So the evidence of improvement is essentially one, like galactomannan monitoring. Now, for patients with successfully treated pulmonary aspergillosis, it is recommended to have secondary prophylaxis to prevent recurrence. Another thing to keep in mind is that reducing doses of or eliminating altogether immunosuppressive agents when feasible is advised as a component of anti-aspergillus therapy. This concludes this presentation.